So traditional treatment is, of course, not only compression therapy and anticoagulation. So during the last, I would say 10, 15 years, new technologies came to the market, which of course are complex. It means it started all with local thrombolysis therapy, which causes issues like bleeding complication and not very good outcome in some of the patients. It then changed to a more endovascular treatment with different devices using combination of less thrombolytic therapy and aspiration thrombectomy, so pharmacomechanical thrombectomy, but still have the challenge of bleeding complication because we are using localized therapy, thrombolysis for this combination therapy. Now the real important step forward is that we, with the new devices, have the possibility to avoid completely thrombolysis, just focusing on mechanical thrombectomy. And I definitely see the advantage in that point. With this mechanical thrombectomy, we are very fast in thrombus removal. We are not giving any thrombolytics to the patient, so we are avoiding bleeding complication. Patient doesn't need to be sent to intensive care unit and can be sent home the day after or 2 days later. So we are talking about a good safety profile, good efficacy profile, which of course need to be proven also in prospective studies, but also cost effectiveness. We are aware, and we have data, the more thrombus we leave back in the patient, the higher is the risk of post-thrombotic syndrome. So we need a high level of thrombus removal, effective thrombus removal. This means that outflow is good after this procedure. That means that venous insufficiency, which then causes post-thrombotic syndrome, is definitely less with this effective thrombus removal. Therefore, it's super important to remove as much thrombus as possible. I would say I call a system efficient if it could remove more than 90% of the thrombus burden in an acute DVT. And based on our data, we could again show that the ClotTriever device did a good job and removed thrombus in more than 95% efficiently out of the body in the patients which we included here. When we're talking about mechanical thrombectomy, we have options. Now we have options, especially with the ClotTriever device, to treat patients with different stage of acute DVT, super fresh, partially organized, or even very organized material. And what we wanted to show and to prove actually is if this is really the point in a daily routine practice. The CLOUT registry already proved this in a super large registry prospectively. We analyzed our data and we did already dozens of ClotTriever thrombectomies just to show if we can really see this also in our practice. Yes, and I can say in these 25 patients, we had a plus 95% thrombus removal of all the state of thrombus in these patients. And this was analyzed by a colleague who is very familiar with endovascular procedure from Berlin, who did this analysis for us, so it's a kind of independent analysis. And I was really surprised to see that how efficient the mechanical thrombectomy was in our patient cohort. And with that, I think we could definitely prove the CLOUT data in our small center analysis also. But what I also learned is how fast we could send the patients back home the next day or the day after. So they didn't even stay more than 1 or 2 days in the hospital. Yeah? And I think that is a point where we can now talk about safety aspects also. No issues in terms of safety aspects, and also cost effectiveness. The patient was not sent to an intensive care unit, just treated on a normal ward, yeah, just received anticoagulation after the procedure. Yeah? So what do we need more? I think that's absolutely key point, that we can treat these patients efficiently and safely.